I can't sleep when I lay in bed. Too much thinking in my head. I don't know what to do anymore. But come on now, tell me the score. Is there anything I can do to get out of these tragic blues? I'm a victim of circumstance. I never really had a chance. I lay down and stare at my feet. You know the world has got me beat.
Welcome to today's edition of Mental Health Matters. Today we're going to be talking about postpartum depression. Here in the studio we have Dr. Shannon Clark on the show, and it's going to be a good one, folks. Thank you, Dr. Clark, for being on our show today.
Thank you for having me.
Yes. I'm so excited about this particular show because it's this particular subject in general is definitely well needed to educate the community. I will be honest, I didn't know a lot about postpartum depression or stress until I kind of talked to you, and I kind of went home and did my research. You gave me a video to watch, and you know, I'm like, okay, this is really interesting. So I know it would definitely be an eye-opener for a lot of people in the community. So I want to start off by just ask you just to kind of tell me a little bit about your position at UC Davis.
So my position at UC Davis is a position that was made for me, actually, because this issue and kind of the disconnect between psychiatry and OB kind of came up a lot. And I did a combined training program, so I did a combined residency in psychiatry and family medicine. And then our family medicine department works very close with obstetrics, so I did an obstetrics fellowship. And the departments we're talking in, our obstetrics department is very, very supportive of our women's mental health. And so having a resident that was in the process of combined training, they offered to kind of gift me the extra training and the longevity, which added to my residency and made it quite long. But
nice.
I mean, there's definitely a need and a gap in care. And so it's called perinatal psychiatrist because we had to come up with a word for it.
Yeah.
And I work with the maternal fetal medicine perinatology group in which takes care of high risk pregnancies. Mm-hmm. And so we call my position perinatal psychiatrist.
Nice. So what made you go in this particular area in the medical field? Because I'm quite sure you could have went into any other area in the medical field of your choice. So why this particular area?
And I have to say, it wasn't really exactly my plan when I went into medical school. I thought I would be a pediatric neurologist. And then when I did my OB rotation in my third year, I loved delivering babies and I loved everything about obstetrics. And so I was kind of leaning more toward family medicine or obstetrics. And then when I chose my residency, just after having rotated in medical school, and every rotation, you can't really separate a brain from the rest of the body, and the combined residency really interested me because I felt like I would need the psychiatry training in whatever I pursued.
Nice.
And so I liked that was there. And there are only 6 programs in the country, and UC Davis had one, and I applied to all of them and got to stay.
Oh, wow. Nice. So let's talk a little bit about UC Davis, how they integrated the staff support for such a high-risk level care in a clinic.
So this is huge because cost is a big thing. And so I feel like what we've done couldn't really be done outside of academia, which makes it a little hard because I feel like there needs to be more support on every level. Mm-hmm. But we have this large student body, so we have a lot of volunteers. Medical students and undergrads and employees that are into teaching are all volunteering their time.
Oh, nice.
And we actually get about 100 applications a year to work with our research group for free.
Oh, wow.
Yeah, and which is amazing to me that our volunteers are so like powerfully passionate about taking care of our moms.
Wow.
And we have volunteers that have stayed with us for 5 years and that have like gone off to PA school, med school, come back, still come around and volunteer. It's amazing.
That's awesome. That's awesome. So let's talk a little bit about the clinic, and because I want to kind of know how did the clinic actually get started?
So the clinic started, so I was actually in residency when we started the clinic, and it started with myself going up to the high-risk clinic because patients that were on psychiatric medications or that were maybe in a psychiatric facility are referred to the high-risk group to see perinatologists because of the medications, et cetera. And there's not that much training in obstetrics about psychopharmacology because there's just, and I mean by no fault or any deficit of the training, it's just there's so much only so much can be accomplished in 4 years. And so they really wanted somebody up there who could kind of assist with the psychiatric medications.
Yeah.
And even though I was only a resident, I had a supervisor in the community who was a psychiatrist. Her name's Dr. Leslie Schrader. She's retired now, and she also had done an endocrinology fellowship with hormones and women's health. And so she would kind of supervise my decision-making processes, so I had someone to check in with. And so I started going to the high-risk clinic every week and managing the patients with psychiatric needs. And that's just it just kind of grew from there.
Oh, wow.
And then when you're a resident, you're very, very busy, and you work a lot of hours. And so I was running out of room in my clinic for new consultations. And so I kind of naively, very naively, decided, I should start a medication management group for my stable patients, and that will free up some of the follow-ups, and I'll have more consult space. And in my mind, this was going to be a lovely little chat with a few of my own patients after clinic. And I mean, if I was on call, whatever, like I would have figured out. And most fortunately for myself, there was an OB nurse who was going through her MFT program. And she said, we get calls all the time in advice nursing postpartum, and people's insurance cuts off from the OB Global at 6 or 8 weeks.
Wow.
And she felt like she was getting calls from maybe pediatricians or people with concerns about postpartum depression, and she didn't really have any referral process to offer anyone except to say, look at the behavioral health on your insurance and try to get an appointment. And in the meantime, she just had this list of people that she kept calling and checking on. And she said, I'll do this with you if you'll take my list too.
Wow.
So lucky, because she's amazing. And so, but if I didn't have someone who could always be there and I don't know what I was thinking. I was naive. But she'd worked for many OB groups in the community, and she said, this is going to be big.
Wow. Wow.
And so she knew better than I did.
Yeah.
And having her there was and so we started with a small group of like, I don't know, maybe 5.
Wow.
And now we have 60 active people that just come to just in the group visits.
Yeah. And it sounds like she was kind of like your mentor as well. So as a mentor. Okay.
In the end, our patients were our mentors because both of us would check in with Dr. Schrader for guidance, and then most of what we learned, because this hadn't been done this way before, was from our patients.
Oh, nice.
Honestly.
Nice. So let's kind of talk about the services that you guys provide at the clinic, because I'm sure it's a lot of good services out there that the community would definitely benefit from.
So in our high-risk OB clinic, we do all the things that would be done in any high-risk OB clinic. So we offer preconception visits for any reproductive age woman that's on any kind of psychiatric medication and may want to continue or not, or however they want to plan their pregnancy. Most pregnancies aren't planned, so so we do those. And then we do full prenatal care. I also deliver, and then we do postpartum care, and then our connected group, which is the medication management group, a lot of people choose to refer into that group, and that goes for all of pregnancy for a full 1 year postpartum.
Oh, wow.
Because the true definition of a postpartum mood episode is anything within that 1 year, not anything within 6 to 8 weeks of your OB Global insurance.
Yeah.
And so to make sure we had that coverage and kind of bridge that gap in care, we're able to offer the group visits and continue to manage medication for breastfeeding women, or, I mean, for any woman that needs support.
Yeah. So if there was a woman that was watching this show and she was, needed you guys' services, but she didn't have insurance, like how do you help women like that who, may need this type of services but don't have, the insurance coverage to pay for it?
So for pregnancy, there's always pregnancy restricted Medi-Cal. There's always some kind of insurance. So as far as coming into our clinic, that's not a problem. And that goes back to our support staff too. That's awesome. I feel like our department really does care about maternal mental health. And so Sherry Hancock is my referral coordinator, and I talked to our insurance person today, Holly Costas, and she said she has not had trouble with any denials.
Oh, that's awesome.
And she said she had recently looked at it for some of our longer term patients.
Okay.
And so because pregnancy is covered, and then if the patient opts to opt in for the connected group, that is entirely off insurance because there is really no good way to bill for that. And our goal is that it's easy and the continuity of care is there. And so if you've had the consult while you were pregnant with myself, and we've referred you into the group, you have that service through your postpartum.
Oh, that's awesome. That's awesome. So does the same thing apply for UC Davis as well? In order to get the services at UC Davis, do the woman has to have UC Davis insurance plan?
Honestly, I don't know how insurance really works.
Okay.
But I know that in general, pregnancy is covered.
Okay.
And it seems like we're able to see most anything except if you have like Kaiser, because then you go to Kaiser.
Yeah.
But yeah, I don't know honestly how it works.
Okay.
But I do know that our referral coordinators will work it out if there is a high risk issue, because and make sure that the person gets into our clinic and gets seen.
That's awesome. Awesome. That type of services is definitely needed. There are a lot of women out there, in the community that may have a mental health diagnosis and, maybe become pregnant and really don't know where to turn and don't know what to do. I know that video that you suggested I watched that, and one of the things that stood out to me was there was a girl, and she talked about how after she had her baby, she didn't know how to connect with her child. And she was saying that nobody taught her or showed her how to connect with her child. And I started thinking to myself, like, man, that's a horrible feeling not to have that support system there to help you through during that time,
And I think this is something that really is stigmatized and just probably not talked about enough. That ultimately, I mean, it takes, not everybody has that, like, oh, I had a baby, I'm so happy. You just brought home a stranger.
Yeah.
And it takes a lot of work to learn how that little person works and honestly, it takes more like 4 to 6 weeks to start feeling the connection, because it's an entire life and identity adjustment. And if a person could, in the time it takes to make a baby and a baby comes out, change their identity to that of a mom, if that happened just that quickly, that adjustment, that would be great. But it takes a little bit to, your world's changed forever. And I feel like that's something that women feel so ashamed of, and they tell me behind closed doors after a couple weeks, and I'm like, you're going to connect with your baby, and it's okay. And, we can work through that. That's awesome. Yeah.
That's awesome. So why do you feel that there are not more integrated models of care out there?
It's a lot to do with how insurance is set up. Behavioral health is always a carve-out from any insurance. It's just how it works.
Okay.
And so, like, from Medi-Cal, it's always some other phone number on, and everything else is medical, and then there's some other phone number that you call for behavioral health, and then there's some wait time, and then there's a disconnect because those notes and documents, as they should be, are sensitized and protected. So they don't even necessarily need to tell us.
Yeah.
But it ends up being the patient that has to communicate between the psychiatrist and the obstetrician if they choose to.
Yeah.
Versus a more integrated system. Or your behavioral health carve-out may not necessarily include the place you're being seen at.
Yeah.
And so, like, Medi-Cal, for example, I think has very like they use more the RST system, and it's not necessarily like care at UC Davis Psych where we are able to kind of go back and forth, and that's not unique to UC Davis. It's all insurances.
Yeah. Well, that's why I think it's important to have clinics, like yours, because the services are there. Regardless if the women have the insurance component or not, they can still get what they need at the clinic. So have you guys experienced any barriers or challenges while working at the clinic?
Yeah, definitely. And so that's been one of them, because traditionally, like, a person that does a gynecologic exam doesn't then turn around and do a group with you and do the psych care. And so there's a fine line with boundaries. There's a very fine line that we walk with boundaries. And then also, myself as a doctor and then my nurse, we know things about the patient's medical chart, and then we have these women in a group, and there's a lot of HIPAA stuff where, you know, we absolutely don't, unless the person brings it to the group, we don't offer up anybody's information. But barriers have mostly been with billing. And so it was a matter of being able to show, like, this actually helps our clinic and helps our outcomes, that we're able to just offer it for free, because there is no way to bill for it.
Wow.
And it opens up more consult slots, and it also, allows us to have better outcomes for our moms.
So how many women would you say the clinic provides service to, just say within a year's time, if you had to guess?
I know since 2009 we've had 400 and some odd mom-baby pairs graduate, which means they did the whole 1 year.
Yeah.
And then some people don't graduate because they are coming from way up in Northern California to come to a high-risk center.
Wow.
And once their baby's home, it's just coming down here is... So it's, I'd say, I don't know, maybe 70 a year.
Wow. But that's pretty good, though. That's really good, because, they're coming to get a need met, and regardless of what, or how society think about mental health, the ones that's not educated about it. Because, as you know, some people don't come forth and get the service or the help they need because the stigma.
Absolutely.
That's attached to mental health. So I think that's an awesome thing, in my opinion.
Yeah.
So,
there's that, and then there's also what often makes it to the news or to the media is very, very bad outcomes where something's happened to a mom or a baby. And so I'll have moms come in and they're like, they feel almost guilty for asking for help as though they don't deserve it.
Yeah.
Because they don't want to hurt themselves or their baby.
Yeah.
And it's like, well, that doesn't mean that you shouldn't have help for depression. Exactly.
Yeah. So tell me a little bit about the connected group visit at the clinic.
So that's probably the best part of my week. So the group visit, because it goes from pregnancy all the way through a whole year postpartum, we offer childcare for kids that are older than 1, because we don't want any mom to not be able to come because they don't have childcare for their older children. And so there's that aspect of it. So we have our volunteers for that. And then the babies can come into the group. And I think for the moms, it's really helpful to see the whole spectrum, where if you're pregnant and you're going through a hard time and you can see a mom with her baby maybe 6 months out that's still coming to group, and that she's on the other side of it, and hear her story, And for the moms that are on the other side and that are still coming, they tell us they like to still come because it reminds them like how important managing their mental health is.
That's
and
awesome.
Talking to the other women is important to them too.
Yeah, that's awesome. What type of women do you guys have that mean as far as the demographics is concerned, like cultures? Let's talk a little bit about that piece.
So it's been interesting because problems that we thought we would have didn't turn out to necessarily be problems.
Nice.
Our translation services at UC Davis actually volunteered to help us.
Wow.
And we thought this would be a nightmare in a group. Because, I mean, at one point I remember we had like a Vietnamese, Spanish, and I think a Russian, like with three of them kind of going. And it actually worked out. And so because the translators are willing to come and they sit right next to the person, kind of talk quietly.
Wow.
That's been really helpful. So we thought that would be a bigger barrier. To some degree, I'm sure it still is.
Yeah.
A barrier for somebody who has like absolutely no, like it might be a lot flying around. So that, I don't mean to say that it's not 100% of a barrier. And then we have women of all age groups, all socioeconomic classes.
That's awesome.
And it's from homeless to like, I mean, I don't want to, like to people that are like flying airplanes and things like this. And so, and like they're very cohesive and very protective of each other and very much like, you know what, anxiety feels bad or depression feels bad or feeling a disconnect from reality feels bad no matter what you have.
Yeah.
Because we'll get a lot of guilt from our moms that maybe have more. And they'll say, oh, maybe I shouldn't be taking time tonight. And it's always somebody who will jump in and say, it feels just as bad even if you have a support person or it doesn't feel any better for you. And I feel like they're so protective of each other. It's amazing.
Yeah, so it sounds like they've created their own support system within the group, so to speak. Yeah. So how do these women hear about the clinic?
So when they come in for a consult with me first, because some of our patients are still, maybe in the throes of psychosis or a manic episode, and that's not appropriate for a group. And so I always have a consult with all the patients first. Some need a little bit more med management before we can refer them in to group, but they come for a consult and then I refer them or I offer it.
That's awesome.
Some people, absolutely don't want to take a medication, so it's another form of treatment that we can offer.
Yeah.
And for some people, having the support is the treatment.
Okay. So speaking of medication, are there certain medications that women should not take while pregnancy if they have a mental health diagnosis? So, I mean, Depakote is the first one that comes to mind. High rate of spina bifida with that particular medication. And just over the long term for women, the bone density loss and things like this. And so hopefully in the long term for women, there's a better medication for that particular woman, maybe. Yeah. But so that's a definite no. But for the most part, if a woman comes in on a medication and they're already past embryogenesis, meaning like already past 9 or 10 weeks of pregnancy, and the medication works, I'm not going to risk destabilizing someone because the baby's already formed. Yeah, exactly. And so I don't want to take away something. If it's Depakote, I'm going to take it away. But but for the most part, and of course there's exceptions to every rule, but I'm not going to change something just for the sake of like this has a better pregnancy category. Yeah. Because what if it doesn't work and then we don't know what 2 fetal exposures means? Yeah. And then we got to go back to the thing that worked, and you end up going down a road of multiple exposures to that fetus. And so if something works and the baby's already formed, we'll do the proper studies imaging-wise to make sure everything's okay. Oh, wow. That's awesome. So, you know, what I like about the information that you're sharing on the show is not only are the women obviously able to get, the level of care through UC Davis, but, the clinic serves as kind of like an aftercare in a sense too, is what I'm hearing, which is really needed.
Yeah, absolutely. One of the biggest things, and this is how we learn from our patients, is that, normally people have that 6 or 8 week postpartum visit, and then they're, back to their primary care, off in the world. But we don't really ever know when they stop breastfeeding, and so when we have them for a whole year, because that's another big hormone shift and huge risk of relapse at the time of stopping breastfeeding if there was a postpartum mood episode, and so, or when there's another hormonal shift. And also just kind of like looking at what kind of birth controls are tolerated and going to be important for any individual. So because we have that like longitudinal care afterwards, and we know how mom and baby are doing together, and when someone's thinking of, stopping this or that, or then we know how to manage it medication-wise or therapy-wise.
Yeah. So for those that may be watching the show, what is postpartum depression?
So postpartum depression is essentially you know what? Even I have a hard time answering that question because there's so many things that should well be normalized in the postpartum period, like having low energy, not having a normal eating pattern, all of the things that meet criteria for depression. So postpartum depression, to me, includes a huge anxiety component. I've not seen postpartum depression without anxiety. So there's actually a term out in the world, they call it PMAD, like postpartum mood and anxiety or postpartum mood and anxiety depression. I don't know. Anyway, something like this. But the A means anxiety. Okay. however we're going to put that. And so it almost comes out looking a little bit like a very much anxiety-driven depression. Yeah. Because there's a thought that kind of comes into somebody's mind that and most of the time it's very much concerned about their own health, they're responsible for somebody vulnerable, and they know this subconsciously, consciously, and they're sleep deprived, and they're tired, and they're a feeding machine, and then they worry about their own health, the baby's health, and they can't stop thinking about it. And anxiety is so physical that then all of the sleep deprivation keeps you awake, it lowers your immunity, and just the stress and tension of all of that then drive a depression. And so mood decreases, and like mom and baby, the relationship there turns into like, I can do what I need to do to take care of you, but everything, all the emotional reserve and enjoyment of it all is sapped out. So depressed mood, little enjoyment in the experience, maybe feeling not bonded to the baby after some time. And then of course, like any thoughts of harming yourself or harming your baby, or just wanting to end it, just wanting to run away. Yeah.
So can a pregnant mother experience depression during pregnancy? Absolutely,
yeah. And so, and I mean, of course, people may have diagnoses beforehand, before getting pregnant. Yeah. And so these are risk factors for then having a mood episode afterwards. Okay. And a lot of it is neurohormonal, and without getting too much into the biochemistry, right when a baby's born, so you have these high levels of like progesterone, allopregnanolone, and progesterone to convert to allopregnanolone needs serotonin, and our body doesn't just make more because of a high level of progesterone. And so right when the baby delivers, allopregnanolone drops. That's what serotonin kind of turns progesterone into. And it binds to GABA receptors like a Valium. So it's our neurosteroidal, like natural kind of calmness. Okay. But it drops precipitously in the postpartum period. And so there's almost like this hormonal setup already. And if you've already had a major depressive episode or a prior diagnosis of really, any mental health struggle, then you're a little bit predisposed, or a lot predisposed already, to like these big shifts and this big adjustment period in your life being a precipitant for another mood episode.
Yeah. I know eating disorder is somewhat associated with that as well. I know sometimes women, when they do get pregnant, a lot of times their eating habits kind of get off track a little bit. Some of them eat things they don't normally eat. Some of them eat too much. Some of them don't eat enough. So is that also considered somewhat like a mental health diagnosis, or is it just normal when a woman gets pregnant?
Part of it has to do with what the hormones do to your sense of smell and taste and what's okay. But then another part of it is that gaining a lot of weight does kind of increase these like inflammatory pathways. And inflammation is like well known to be associated with depression, and certain hormone pathways like then lead to higher cortisol during the pregnancy. And we don't know what it all means as far as cause and direct effect, but cumulatively that can't be a good environment for the mom or the fetus. And so I don't know that I would necessarily say that part is an eating disorder. But if you have an eating disorder already, then that's certainly going to be more dangerous when you're pregnant.
Okay. So how? Okay. Let me think how I'm gonna write this. So, do you think that postpartum depression? Do you think that it's a public health issue, or do you think it's a woman issue, so to speak?
So, I 150% think it's a public health issue. Because this is a big deal. This is the next generation of people that we're raising, and when a baby's born, their brain's still developing, and socialization and attachment and all of the we have great in psychiatry long-term studies on attachment, and a depressed mom will have struggles attaching to her baby, and then they don't learn that social smile as early, and then maybe have struggles later in life, just with socialization if they have like poor early attachment. And so it's actually one of the things that's part of our research that we test for is the style of attachment. We do the old school strange situation protocol, like the two-way mirror, and like the stranger comes in and the mom comes in. But like we do that at 1 year out. Just to see how people do. But we also kind of teach our moms, like, the baby doesn't know that you're depressed, so just go smile in the baby's face like 10 times a day. He's never going to think, lady, you're faking it. Like, it'll be okay. And so, part of it is also working on that dyadic relationship and having, the babies there too, and working with educating the moms about establishing that relationship with their babies. And moms feel so much better when they feel like they're doing something to forward that relationship, because there's so much guilt that comes on top of everything else.
Have you experienced just any patients or women coming in and they needed a certain level of medical treatment, but they just refused to get that level of treatment, the medical treatment? And how did you deal with that, or how would you deal with a situation like that?
That is incredibly hard, because these are adults generally. And so it's a lot of the same problems that we always find in mental health. You can't make somebody do something, and you don't want to wait until the bad thing happens to make them. To some extent, our group can be helpful for that, because I can beg and beg, like, just come once and meet some other moms. You don't even have to talk. At least you'll know me. And sometimes that does help. But if somebody is very resistant, and sometimes there's nothing that is going to change that.
Yeah.
And it's actually, as a doctor, it's horrible.
I know. And the reason why I asked you that question is because I know somebody who had a mental health diagnosis, and the parents of this person did not go and get her the services or the treatment that she needed growing up, and and everybody knew that something was going on, that she needed some help, and so she ended up having her first child, and everything was okay, but what happened was this young adult wasn't getting the proper medical treatment that she needed. And so she got pregnant again, and she had her second child, which was a little boy. And so the doctors was really concerned because they knew something was going on with her body, and they was actually trying to motivate her to, come and get this issue taken care of. And she didn't go, and so she ended up getting hospitalized, maybe like 2 or 3 weeks after she had her son, and eventually she died, And to me, it was a really, really sad story because, had she got, I feel that if she would have got the treatment earlier for her mental diagnosis, or for her mental health, should I say, then she would have been able to make better decisions. But unfortunately it didn't happen like that. And because the stigma that's attached to mental health, I also think that played in a part of her parents not going to get her the treatment that she needed.
Yeah, that brings to mind a particular patient that we recently had as well, and she actually ended up losing custody of her child for something very treatable.
Yeah.
But her parents had covered up any need for treatment for a very, 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 very long time. And so she actually didn't come into our system, into high-risk psych clinic. She had seen a few different OBs, and then we got her right at the end of pregnancy, and then afterwards could tell something was wrong.
Yeah.
And we tried, but it was just such a resistance and to convincing anyone that anything was wrong, let alone incredibly treatable.
Yeah. How important is it for a mother to have a support system, or support in general? Because I know that there are some women who may get pregnant and the father may abort on them, or their families may feel like they're not ready, and sometimes they just don't have the support that they need. And how important is it for them to have that support system in their life?
It's huge. It's probably, it's probably one of the biggest risk factors, not having any support. And we really encourage the obstetricians at UC Davis to refer people over just for a one-time consult.
That's
if
awesome.
They have risk factors.
Yeah.
Just risk factors. They don't need to have anything going on. They don't need to have symptoms. But if you notice a lot of risk factors for a mood episode, then please refer them so that they're at least referred into the connected group, so they have that service available and somebody calling them weekly for the rest of the pregnancy and the year postpartum. And, they can opt out. Maybe nothing goes wrong. But so somebody like, we get a lot of researchers and things like this that you see, they just moved here, don't know anyone.
Yeah.
And these are people that work indirectly, like with our campus. And we always tell people that have very little family support around them, just make the referral, because you'll need support.
Yeah.
After you've had a baby, and knowing other moms.
Yeah.
And being at home and isolated with a baby, and there's little, at a job, somebody can tell you, you're doing a good job. Mm-hmm. You're doing this right. And a mom alone with a baby doesn't get that feedback. And they often feel like they're not doing anything right.
Yeah.
They're usually doing fine.
Yeah.
But there's just no way to, it's a whole new experience and a new identity, and they're alone at home with baby.
Yeah.
And they're it for taking care of that baby.
Yeah.
And so having support is big.
Yeah. I know, my sister, she probably watched the show, she's going to kill me, but I'm going to say it anyway. I know when she had one of my nephews, and to this, it is so funny because I was actually thinking about this on my way here. And I think I shared a little bit this before we started the show, but she did not really have a lot of support. You know, her husband at the time was not around, and she went into labor on Christmas. And I remember me going to the hospital with her, and I was thinking to myself, like, wow, like, and we had a house full of family members over. And it's like, why ain't nobody going to the hospital with Regina, you know? And so I offered to go, and when I went out there, I told him I was the father and just kind of, you know. And so when I went in there, I'm like, I cannot do this. I cannot do this. I was like, it was just too much for me. So of course I went in the waiting room, but I wanted to be a support person for my sister. I didn't want her to, you know, to go to the hospital by herself and deliver this baby by herself and not have anyone there. And I think that's you know, that's not it's just, you know, women need that. You know, even getting pregnant in general, just going through the morning sickness and the things that they go through, they need a support system there to help them, to talk to them, to comfort them, and just to listen to them, you know, because I know sometimes the emotions is kind of, you know, up and down, a lot of crying and things like that. So, but just not to have that support there to me, it's not a good place to be, you know.
Yeah.
So to speak.
Yeah. No, that's very big.
Yeah. So let's talk a little bit about the stigma that's attached to mental health and that's attached to, you know, some of the stuff that these women may go through that you provide service for. So talk a little bit about the stigma that's attached to mental health.
So I would say starting with the pregnancy in general, people that may already carry a diagnosis may need a medication. Like taking a medication in pregnancy is like, what do you do? Like they're very ashamed to even tell their families that they've chosen to remain on medication during pregnancy. But what we do know is that mom being in the healthiest state she can be along the neurohormonal axis is like the healthiest thing for a baby too. So it starts there. Yeah. And then in the postpartum period, all these things of CPS and social work and things like this get conjured up. If somebody was to go ask for help, the first questions that they're going to get asked are, do you want to harm anyone? Do you want to harm your baby? Do you want to harm yourself? Okay, well then you don't need help right this second because you don't need to be 5150.
Oh, wow.
And so, because that would be an emergency workup. So then how do you get into mental health services? You call this number on your insurance card and maybe wait like 2 months.
Wow.
For an appointment. Some may be better than others, but it's going to be a wait.
Yeah. And
sometimes you don't have, a lot of times, like you don't have, you're just getting more and more tired, less and less emotional reserve. And asking for help and not saying that motherhood is like the most amazing thing that's ever happened, which I feel like most moms feel that they're expected to say. Yeah. Because I've had moms pull out their phones and say like, look, this is what I'm posting on Facebook. This is not my life. Wow. My life is horrifying right now. Yeah. But they feel like they need to put that out there to the world because culturally that's the expectation that we've set up. This should be the happiest moment of your life. And you should 6 weeks from now be, you know, good with your new identity and all this and go back to work. Yeah. And that's how it should go. Which is, that's a lot. Yeah. I mean, even a puppy is more work than like 6 weeks. Yeah. And so I think it's a lot of the expectations that and the pressure that people feel that defines what a mom is, and then not living up to it. And then that makes them tell themselves internally in some kind of way, I'm a bad mom. Yeah. And I'm not good at this and maybe I shouldn't be doing it. Yeah. And to go ask for help for that is like carries this like shame and guilt on top of already feeling bad.
Wow.
When maybe there's so much at play just with what's going on in the body and taking care of a child, that's a lot of it is probably just like give this person a break.
Yeah.
And then, then there's the other part that this could go on for a while and needs to be treated.
Yeah. Wow. So how can we as a society work against the stigma, so to speak, because, there are a lot of intelligent people out here, but I think also a lot of people don't know about mental health. They just have this one way of thinking, and, and people with mental health diagnosis, in my opinion, are some of the most brightest people that I've known. Mm-hmm. Trust me when I tell you that. Mm-hmm. I really believe that because I work with a lot of people that are highly intelligent, highly educated, and I know people who don't have a mental health diagnosis is on the opposite spectrum, so to speak, But what can we do as a community to break this stigma, and even in just across fields, medical fields, or, even if it's somebody working in a restaurant or wherever, like how can we educate the community about mental health where we can just work against the stigma that's attached to it?
I feel like in medicine, like during prenatal care and right after prenatal care, just automatically using a screening tool or something opens up the door to the conversation. And there's a lot of questions about using screening tools when, okay, so somebody scored high on a screening tool, then do you have something to refer them to?
Yeah.
What's going to happen? But if nothing else, it opens the door to a conversation with their doctor and normalizes it because it's just there.
Yeah.
As part of the packet.
Yeah.
And also at discharge from the hospital after a person has a baby, our labor and delivery nurses are right now working on their own project because they're like, we show people all these videos about, breastfeeding and safety and this and that. And so they're now also showing one about postpartum depression. And if you have these signs, because that's the more common complication is actually a mental health problem. So, I mean, from the medical side, we can kind of normalize it there, but that doesn't mean that people necessarily just trust doctors and the medical establishment at large. Or that, your family culture just isn't okay with I find a lot of women, what am I trying to say? Like, will maybe come in and say, well, what's it going to say on my doctor's note? Because I've been telling my family I'm coming in to have my repair from the delivery evaluated. And that's why I'm having all these additional appointments, because they don't want to tell anyone.
Yeah. Wow.
So I think probably change has to just grow.
Yeah.
You can't really force it, but if we continue to normalize and continue to move on, then as generations go by, it will be just the more normal thing that this is an important thing to screen for and talk about.
Yeah.
As a community, I think, having just the education out there, but then again, that comes from the doctors. Typically.
Yeah.
I think inviting family members to visits, and sometimes that does not work out, I will admit. And those patients will tell me that it's just not going to be okay. Dr. Clark, like, you trust me, you don't want to talk to my mom. And okay, so. So I'll just take their word for that. Some people are like, well, maybe we could try.
Yeah. I do know that I have a friend who he hasn't been diagnosed medically, but he definitely he deals with like a severe case of depression and anxiety, and just recently he was having an issue with pain medication. He got addicted to them, and and so I've been trying to work with him and talk to him about getting into a drug rehab program. And he was so against it, you know. And so he's like, oh, man, I'm just going to stop on my own. And I'm like, well, you've been trying to stop it on your own for maybe like almost a year. You've been unsuccessful. So, you know, let's look at other methods here. And so finally, he came clean. He said, man, you know, I've never been in a place like that. And then, you know, what are people going to think? And, you know, and so, and I was so grateful that I've had the skills and the background to be able to really talk to him about mental health and to let him know that this is for your best interest. You know, it doesn't matter what people think or say about you, you know, because the truth be told, there's a lot of people or family members that have some sort of, you know, challenge or mental health diagnosis, you know. But I say you have an opportunity to really get help for yourself, you know. And so he went in and you know, went to Napa actually and got in a place, you know, to move forward and get him some help. But he was willing to not, you know, go in there and get the help that he need because of what society and family members may think, you know. And it's so sad even with that situation because he has a family member that is kind of going through a situation and the person pretty much is not getting the help that she need because her parents, you know, and I'm like, man, you know, and I try not to say too much about that because I don't want to, you know, step on her toes and stuff, but I'm thinking to myself like, yeah, that situation definitely needs to be taken care of because it's really starting to affect his sister and the child and his nephew, you know.
Yeah. No, and that's one reason I really love working in OB. And especially, like, I really have to hand it to my patients who voluntarily come to a weekly clinic that is not part of their prenatal care.
Yeah.
Because they're trying to be the best mom that they can be, but they're also breaking family patterns.
Exactly. And that's important.
And over the long term, like what they're learning there and what they take from it, as their child grows and sees how their parent handles, like, problems happen and this is how we deal with them.
Yeah.
Then, you know, they'll have tools to teach their child for how to deal with problems in the world.
Yeah.
Versus there just aren't any, let's just hide it.
Yeah.
And then the kids will struggle for coping skills.
Yeah, exactly. So what advice or what would you say to a mother who may have a mental health diagnosis and who have a child and she felt like, you know what, my life is over, you know, I want to go to school and become a lawyer, a doctor, and you know, I just can't do it. Now, what would you say to her? I'm just curious, what would you say?
I mean, I would definitely encourage her that there are barriers, you know, that can be overcome to go to school and to get the help that you need, like through some kind of way. Because I know for myself personally, we had some family stuff toward the end of my high school years, and I didn't conventionally graduate, and I had some little job as a secretary, but I didn't actually start college till I was 23.
Okay.
And because I didn't think I could.
Yeah.
Because I didn't really finish high school properly. And I worked for this attorney, and I explained this to him, and he had me go see a school counselor, and she said, you should maybe think medical assisting school. And I went back to him, and I'll just never forget his words. He was like, oh, no. That is public school. You have the right to try and fail. Do it little by little. Do whatever you need to do. But you don't get to be told and marginalized into because you have this, or that. And so I think I would probably try to pay it forward as good as that person did for me and say, you know what, you don't have to be marginalized into whatever you're labeling yourself as. Like, I'm a single mom, this is it. This is all. Like, little by little, time's going to pass anyway.
Okay. Thank you so much for that. Well, Shannon, I really appreciate you being on the show. You shared a lot of good information. I know somebody's going to definitely learn a lot from this program because I know I have learned a lot just by my interaction with you through email and just, you know, face-to-face contact. And so I want to thank you for being on our show. And that's it for today's edition of Mental Health Matters. If you enjoyed this show, or if you have questions about this show, or if you want a copy of the show through DVD, you can reach me at 916-366-4600. Thank you.
When I think of where I've been, the good times and the bad, on a scale of 1 to 10, either way I'm glad, 'cause I'm not alone. As I'm reaching for the phone, your voice is there, you really care, you're my comfort zone. Sometimes when I'm lost, crushed beneath the pain, though I can't afford the cost, I just smile and play the game. But there's a healing place where I cannot pretend. Your smiling face, your heart's embrace heals me again. So even when the storm is strong and I'm deaf to my own cry, I faintly hear a distant song, and I simply can't deny that I'm not alone. 10,000 times I've known my best bet is that first step for hope. Trying to stand tall, I'm haunted by the past. With my back against that wall, one thing is clear at last. The kind of love you show to me flows from an endless stream, with shores so wide it won't subside. My mind had never dreamed how I'm not alone. Even when I'm on my own, your gentle touch is much too much to let me roll. So even when the storm is strong and I'm deaf to my own cry, I faintly hear a distant song, and I simply can't deny how I'm not alone. 10,000 times I've known my best bet is that first step for hope. When I think of where I've been, the good times and the bad, on a scale of 1 to 10, either way